没声音的。耶，我不是点的循环播放吗？啷个没得了呀？
刘根儿没声音了哦。
没声音，六根
啊，
儿是。
刚刚那个是有声音的，那个是没
前面两
得。
个是不是？哎，六根儿是也没得。
我还以为
哎，
我
我
卡得那个程度了呢。
听了一个视频的啊，我不是点那个循环播放吗？我的循环播放起来了。编辑显示循环，马上，我看它得不得循环哈？哦，循环。
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, Haifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues.
我开始放人了。
Ultrasound-guided Haifu involves Haifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrates an echogenicity or grayscale changes in the ultrasound. An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, Haifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues. Ultrasound-guided Haifu involves Haifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrates an echogenicity or grayscale changes in the changes in or grayscale ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, Haifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body without causing any damage to the overlying surrounding tissues. Ultrasound-guided Haifu involves Haifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrates an echogenicity or grayscale changes in the ultrasound. An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, Haifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body without causing any damage to the overlying surrounding tissues. Ultrasound-guided Haifu involves Haifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrates an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patient's response to ablation, ensuring a safer and more controllable therapy. An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues.
Hello, Silver.
Hi, Dr. Lee. Hi, Dr. Chang.
Hi,
Hi.
so continue.
Yes.
Okay.
Hi, Dr. Lee. Hi,
Dr.
Lee.
Yang. Yes, nice to meet you. Okay, good. Because this afternoon I feel a little bit not so well, so I have a pre-recorded.
Okay.
So later on they will be have some show the video. I think that will be much easy, and I will answer the questions. Yeah. Okay. Yes. And the Shiver, how about recently? No, you are most famous one in
I am not as famous as you, Dr. Lee.
just the Haifu, the IVF, and also endoscope surgery, and maybe LOBA. Did you begin? I have a LOBA.
Haven't started yet. Haven't started robot yet. We are going to start soon. I'm sure you're doing robots as well, isn't it?
Oh yeah.
Not
So
much.
I think you are too busy, you know. So every day you put your schedule on the just one thing, Haifu, and maybe today, and one day for endoscope surgery, one today for the IVF. There's the day that every day have been occupied already. Yes. So yeah,
It's crazy trying to do too many things actually.
yeah. But you are work so hard. That's you deserve it. Yeah. Okay.
So, Dr. Chang, so how are we going to do this? I think you better. We are supposed to. I supposed to give one opening remark, and then Dr. Chang will be giving another opening remark, and then Professor Lee will speak. Or not, Professor Lee will speak on behalf of APH. Am I right?
Yeah, but that's okay. You most of you will have an opening remark. Maybe I don't need to have a pre-recorded to have a opening remark. That will be okay, and I will forward to have a speech. Yes.
Okay.
And it's just on video. Yes. That's
And
okay.
then when introducing the speaker.
Ladies and gentlemen, welcome to Apagismiv's Haifu series webinars. The theme of this meeting is prevention and treatment of cervical cancer. Thank you everyone for joining. Let's get started.
Dear friends and colleagues, good evening. It is with great pleasure to welcome you all to join 2024 APEC ISMIS Haifu Webinar. And I would like to thank Chongqing Haifu to organize this wonderful event. The theme of this webinar today will be focused on the prevention and the treatment of the cervical cancers. Promoting this non-invasive technique is also the major mission we collaborate with the ISMIS. I hope through the webinar, Haifu treatment will become more individualized, particularly as the physicians have access to multiple avenues for addressing the needs of the patients. I hope more and more gynecologists can absorb more knowledge of Haifu and endoscopies, the non-invasive therapy and the minimal invasive therapy that advocate women's health and improve the quality of life, which the webinar a big success. Thank you.
Perhaps I can say a few words. Hello, everyone. My name is Dr. Selva. I am actually the Vice President of International Society of Minimally Invasive and Virtual Surgery. And I would like to welcome you all to this webinar. Since the outbreak of COVID-19 in 2020, International Society of Minimally Invasive Surgery, as well as APEC, have jointly held 12 webinars to publicize the latest medical advances in minimally invasive and non-invasive medicine. More than 1,500 doctors from various countries have participated in, and I can see that they are all interested in new technologies. The theme of our webinar today is prevention and treatment of cervical cancer. Vaccination, screening, and treatment are three important measures in the global strategy of accelerating the elimination of cervical cancer as proposed by WHO. In the lecture content of our webinar today, Professor Shi Chuiling and Professor Wang Zi will talk about focused ultrasound, which is a prevention treatment from the stage of precancerous lesion of cervical cancer. Professor Chilong Lee will give a lecture about minimally invasive therapy after diagnosis of cervical cancer. All are very interesting topics. Doctors can leave your questions in the chat area or ask questions after the lecture. At last, I would like to announce here that ISMIF will hold a short-term training course on focused ultrasound treatment of tumors and gynecological diseases, including cervix and vulva, in Manila, Philippines in July this year, which is free of charge. Now, doctors who are interested can register for this training, and 20 doctors will be selected and will be recruited for this course. So I will be there as well, and I look forward to seeing you all in Manila.
Now it's my turn, right?
Yes.
Yeah, okay. Hello, everyone. Actually, I want to say good night because because I want to go to bed because I have a very busy day today, clinical and operation day today. But it's my honor to be here to introduce our chair, Dr. Silva. Actually, he's a very wonderful guy, wonderful master. Actually, I love the second name because the second name is Superman. So every time I meet him, just like I hold a Superman. I'm sure you will trust me because after I introduce this wonderful guy, Dr. Silvan Subramania is expert in infertility and work in medical medicine and he also is the president of the IVF Center and the Haifu Center. Dr. Steven, surgery for the minima inventory at Lincoln Chang'e Memory Hospital. He is also of the past president of the APH, and also it invite and promote minima invasive surgery very, very hard. So the Dr. Steven Supermania have a lot of experience about minima invasive surgery, and also tonight the topic, the less invasive surgery Haifu. So let's see and let's enjoy today the topic. Thank you, everyone.
Hello, everyone. Let me introduce Professor Chang. He is the superintendent of Ida Chang Hospital, Taiwan. He's the president of the Taiwan Association of the Minimally Invasive Gynecology. He's also the chief supervisor of the Taiwan Association of Obstetrics and Gynecology, the TAOG, and president-elect of the Asia Pacific Association of Gynecological Endoscopy and Minimally Invasive Therapy, APH. So both of us will be introducing our speakers today. Our first speaker today is Professor Chi Long Lee. I think everybody knows who he is. He is he actually runs the APH, the association that is the most famous in Asia Pacific. He's the chairman of the board of trustees of the Asia Pacific Association of Gynecological Endoscopy and Minimally Invasive Therapy, that's APH. He's also the executive director of the Taiwan Association of Minimally Invasive Gynecology, TAMIC, chief executive officer of the Taiwan Association of Menopause. He's a professor at Chang'e Memorial Hospital University. He's also my teacher. I learned most of my basic skills from him in 1994. He's a board member of the International Society of Gynecological Endoscopy, ISG, from 2015 to 2019. So let's welcome Professor Lee Chi Long to give his first lecture on minimally invasive surgery for cancer or for cervical cancer.
Thank you for your introductions. Today, I'm talking about the current trend in minimally invasive therapy for cervical cancer. I'm the chairman of board trustee of APH. And also we have a MOU with the ISMIUS. So I think it's a trend for the minimal invasive surgery and the non-invasive therapy. And APH is a well-known society. And 2019, we have an annual congress in Chongqing, China. More than 3,000 participants attend this wonderful congress. And year 2021 in Japan, but because of COVID-19, we have a WebNet meeting, and also more than 3,000 participants in this congress. And 2 years ago, 2022 in Taipei, that is after the COVID-19, is a very successful annual congress. And last year's 23rd annual congress in Singapore, thanks to the Berners chance holding the wonderful annual congress, more than 1,000 participants in this congress. There are so many new innovative the knowledges in this congress. And this year will be the annual congress in Chennai, India, in 30th October to 1st September. Welcome you to join us. And also our wonderful journal, GMIT. The impact factor is 1.2, and I hope all of you can submit your paper to this wonderful journal. So we know that cervical cancer is the fourth most common cancer in the world, and it's a burden for the global. And so they happen in the low and middle classical income countries. So the competing the health needs impact the socio-economic conditions, healthcare infrastructures. So we know the cervical cancer is caused by the HPV virus, so it should be preventable. It should not be caused so many and attentions or so much money in the treating this disease. So we know what to prevent cervical cancers and what is the best way to treat cervical cancer. Because the HPV infections identified as the primary cause of cervical cancers, maybe more than 99% of cervical cancers, we can find they have HPV 16 or 18 infections. And the persistent infections with high risk HPV can lead to the integration of the viral DNA into the host genome, disrupting cell processes and promoting oncogenesis. And the oncoproteins E6 and E7 produced by high-risk HPV types play key role in inhibiting tumor suppressor proteins and also promoting the cell proliferations and disrupting the cell cycle control, ultimately contributing to the transformation of the normal cell, cervical cell into the cancer cells. So they have another risk factor, just like smoking, immunosuppressions, and multiple sexual partner, and poor nutrition, and the genetics factors include the individual susceptibility to HPV infections. And the early detection is very important because in early detections, we can have proper interventions. And most of the early stage cancers, cervical cancers, is often asymptomatic. So routine screening play a very important role to identify the precancerous lesions and early stage cancers. And also timely detections, we can have appropriate management strategies such as surveillance, treatment, or preventive measures to prevent the progression of the disease to the advanced stages. And the screening guidelines and strategies include pap smears, HPV testing, and the colposcopy is the acetic acid, glucose, iodine, and the screen and treat approach. Sometimes we can have a diagnosis and also have to treat the patient just like a leap. We can have a treat spontaneously with the detect about the precancers or cancer. The current treatment approaches, traditional methods include surgical treatment, radiation treatment, and chemotherapy. And the surgical methods include minimally invasive therapy or open surgery. And we know surgery is cornerstone for the cervical cancer treatment. And also, we also know it's very effective in control the disease and the improve of patients' outcomes. And also, the radiations in the advanced stages is very efficacious. And in chemotherapy, sometimes we need to combine with the chemotherapy to have a decrease the recurrence rate. And recently, they have advanced in cervical cancer treatment, include Haifu. And Haifu have shown efficacies in treating precancerous lesions. And also the immunotherapy, and include the targeted HPV oncoprotein. We can use vaccines or checkpoint inhibitors and adopt T-cell therapy. And we also know the therapeutic HPV 16 special vaccines have shown very efficacies. And also we can use the immune checkpoint inhibitors, ICIS, and tumor infiltrating lymphocytes, TILs. They also demonstrate improved clinical efficacies in cervical cancer treatment. And the target therapy inhibits molecules, typical proteins, specifically expressed by cancer cells to control the growth and the spread. And we also note after surgery or maybe in chemotherapy, we can use the chemotherapy with radiations or with the immunotherapy or target therapy to enhance the treatment outcomes. And also we know they have a promising result from the combination different therapeutic approaches in other cancer. And so it can be improved the cervical cancer treatment outcome. So we call it what is the prompt intervention, open surgery, or we should do the minimal invasive surgery. Before 1993, the first generation surgery, maybe open surgery is adequate. But after 1993, laparoscopic radical surgery began. So maybe that is a second generation surgery, laparoscope maybe the treatment. And after 2010s, the late surgery, robotic surgery coming out. So maybe that will be a good way to do the cervical cancer surgery. And maybe later on, no surgery or Haifu microwave, they have a good method to treating the cervical cancer. So from history, we note in the early stage, 120 years ago, Williams have a radical surgery, and also 1921, Okabashi have a radical surgery, Okabashi method. And after the 2062, the Lower Palmer have a using the scope to doing the tumor sterilizations. And 1989, the Heinrich have the first laparoscopic hysterectomy. In the 1993, Nazar, Carmen Nazars, and also Keru, Daniel, and I, myself, and Dr. Huang performed the first laparoscopic radical hysterectomy. So the radical surgery should be from abdomen or from the minimal invasive therapy. Until 2018, that is the nightmare of the minimal invasive cancer surgery. The publication of the Lake trial, they found the minimal invasive radical hysterectomy for the early stage cervical cancers have a poor outcome compared with the abdomen radical hysterectomy. The 4.5 year survival is the 86, and when compared with the open surgery, is the 96.5%. And also the minimal invasive therapy have the higher rate of the local regional recurrence. And they propose the potential reasons for the inferior oncology outcome is because of the using of the uterine manipulator or effect of the CO2 insufficiency. But I think Confucius has said no to 4 issues. There was 4 no's: foregone conclusions, subjective predeterminations, obstinacy, egoisms. So after the Lake trial published, the European Society have a survey for the cervical cancer treatment. We can find 48.9% the pre-Lake study, they have using the minimal invasive therapy, but in 2020, after the Lake study published, they just have a 18.2% using the minimal invasive therapy. So have a markedly decrease in the using the minimally invasive therapy. Should we object it? Predetermination. So we survey the data from the published the papers year 2000 to 2019. They have 13 studies, and we found the mode of the laparoscopic surgery did not affect the negative cancer factors, and of which drive adjuvant therapy. And in the minimal invasive therapy group, intra-op complication is similar, but they have significant post-operative complications. And in the minimal invasive therapy, they do not increase the recurrence rate or decrease the survival. So we know that disease-free survival is the core value for cancer treatment. So we found the paper is to focus on the size and the site in minimal invasive therapy. So they don't standardize the surgery. No proficiencies in the surgeon, maybe some of them still in learning curve, and inadequate resections, especially in the parametric areas, and the careless of the tumor retrieval. And they had just 1.1 cases per center in 1 year in laparoscopic radical hysterectomy clinical trial. Cannot proficiencies label. And so we have also published our data in the past from the 2009 to year 2014. And we can find in our patient, 69 patients, we frequently doing the surgery. So the operation time just about 3 hours, and the blood loss just 250, and the hospital state 2.8, and the total lymph node at 18.3. Brain training 2.4 days, and follow-up totally we have a follow-up more than 5 years, and in average will be the 96 months, and there were no recurrence and no days, and the 5-year survival will 100%. So here is our measure to get the laparoscopic radical surgery as a probed the measures. First, we insufflation from umbilicus, and after we can increase the intra-abdominal pressures up to 20, and the insertion from the deform point. And after insertion, the deform point, the intra-abdominal pressure decreased to 15. And then exam of the liver, diaphragm, abdomen, and the intestine. Then we doing the lymph node dissections. Because he is not a point, so we just doing the complete lymph node dissection and then coagulate on the uterine artery, and then do the both sides of the pelvic lymph node dissections. Then we do the radical surgery, because we can early detections of cervical cancers and standardize of the radicality technique, so we can have a good outcomes. And also we have the tumor-free concept, and we use the advanced therapy, the instrument. We can find we use the ligature, so very effective even in the uterine artery, IP ligament, just 1 or 2 bite of ligature, they can complete hemostasis. And also we removed the lateral side placopian and dissect the ureter tunnel and identify the anterior placopians. Here is the lateral placopian, and also we identify the posterior placopian, and also the anterior placopian have identified. After that, the adequate the margin have been separate and remove the uterus completely from below. After that, we have the medicular irrigations of the pelvic cavity. So if they have any leak, the cancer cell, they can be washed out. Recently, we have a closure the vaginals, so the probability of the cell cancer leak is quite rare. And the adjuvant therapy in tummy, also the qualified surgeon in the minimal invasive surgery is necessary. So lastly, we can find the hypoglossal nerve preserved, and the splenic nerve also preserved, and it's a nerve sparing radical surgery, and all the pelvic we can examine is quite clear, and also is also standardized. So should not obstinacies. So the RPH have a statement on leg trial, and we announce we hold the different opinions, and the surgeon capability is very important, and the standardizations for the radical surgery is crucial for the radical surgery. And the instrument, we should use the advanced good instrument. And also, we don't suggest to abandonment of the procedures, because we need more study. So we propose a new clinical trial mitral study. And also in the Denmark, they have from the National Cancer Institute, they have 1,125 in 10 years periods, 530 underwent the traditional surgery, and 595 underwent the minimal invasive therapy. And they found now in after 2016, totally they have a complete transit to the minimal invasive therapy. But they found the outcome is the same. So they have conclusion about after the national database, they found robotic minimal invasive therapy in cervical cancer is oncology staff, and maybe have a select by us to the Danish national adoption of the robotic minimal invasive therapy completely transitioned the surgical approach for early stage cancer since 2013. So abandonance of the procedures based on the single randomized control trial may be premature. So in Denmark, they have completely transitioned the surgical approach for the early stage cervical cancers to minimal invasive surgery already. So how can we have a good result? We should make this feasible in the laparoscope oncology surgery. We should use the leaf-on point so we can have full hand surgery. We use the ICG, so we just needed to sampling the sentinel lymph node, and we equip with advanced endoscope 3D or 4K endoscopy, even robotic surgery. And we standardize the procedures and having intimate the knowledge of the tumor-free concept and the equivalence of the advanced surgical instruments. So could minimal invasive complete transition the surgical approach for early stage cancers to minimal invasive surgery? Yes, we can. So the trend will become the minimally invasive surgery. So we make conclusions. The surgical trend is changed. The current trend is the minimally invasive surgery will be the trend all the time. And the minimal invasive surgery go on in cancer surgery. And the Danish national adoptions of robot minimal invasive surgery completely transitioned the surgical approach for early stage cervical cancers since the 2013. And our group, Li Huang team, 100% minimal invasive surgery in the endometrial cancer, cervical cancer, and early ovarian cancer since year 1996. So we can do this. You also can do it. And Haifu vaccinations maybe play a role in preventing of the cervical cancers. So let's have a more focus on the minimally invasive surgery, Haifu, and maybe vaccinations. Minimal invasive surgery maybe combined with the chemotherapy and the radiation therapy, immunotherapy, or target therapy, maybe have a load in enhanced treatment outcomes. If we just doing the surgery, maybe sometimes it's not good enough. The adjuvant therapy include the immunotherapy or target therapy, maybe it's quite helpful for the enhanced treatment outcomes. So we advise you keep up the pace with our page, hold the line with our page. Lastly, I invite you all to the Chennai, the annual Congress in this October 30th. Welcome you to here. Thank you.
Supermania, would you please open the mic?
Oh, sorry. Thank you, Professor Lee, for the lecture. I don't see any questions in the box in the Q&A box.
Yes. Okay. Yeah. So I think the Haifu and also the minimal invasive surgery will be the trend in the preventive medicine and the prevent of the cervical cancer and also the treatment of the cervical cancer. Yes.
Professor Lee, in your department, for all early cancer cervix, do you all still do laparoscopic radical hysterectomy?
Yes, in Li Huang group, we all do the laparoscopic surgery only. Yes, include the endometrial cancers and the early ovarian cancer, just the same. Yes, we have no open surgery. Yes.
Excellent. I think you are leading the way, because many of us who are doing this are very worried because the patients find out about the leg trial, they will not be very happy with us. So we are not as aggressive as you to still continue doing radical surgery for cervical cancer. Of course, for endometrial cancer we do all the time, but for cervical cancer we're very careful.
Yes, so you can find Denmark have a very good, very excellent the data for the cervical cancer. Contrast to the leg study, almost all now the cervical cancer performed in the Denmark. They have is also the minimal invasive surgery by LOBA, but maybe they have the many LOBA in the country, but actually in the Asia region, maybe the 3D laparoscope is quite work well. So you maybe use the 3D and 4K in doing the radical surgery. I think there will be the same outcome with the as the Denmark. They have can transition all the surgery to be minimal invasive surgery. So I think that's possible.
There's one question from Dr. Yuen Go Irene Horn. Her question is, does uterine manipulator affect the outcome? Do you use uterine manipulator or you don't use uterine manipulators?
Yes, actually, you can find if we don't use the uterine manipulator, sometimes the parametrin is you want to take it out a little bit difficult. So the radicality sometimes is maybe limited. So in our group, we all using the uterine manipulator, but after uterine manipulator use, we have the couples, the irrigations to the pelvis, and also we have if they have any parametrins involvement or something lymphadenopathy, we can earlier to have adjuvant therapy, chemotherapy. So I think that is the way we can prevent the effect of the uterine manipulator. Yeah, so we still use the uterine manipulator, and you can find our result. They did not have any influence on the uterine manipulator. We still have a 100% and the survival rate in the 2009 to 2014 during the 5 years follow-up. Just have a 100% survival. So we still use the uterine manipulator, but no influence on that. Yeah.
When you do irrigation of the pelvis, how do you do it? You just put the patient in the reverse Trendelenburg position, that means the head up, and then irrigate to get all the water down. Is that how you do it?
Yes, we just have first we just irrigate in the pelvis. Then we ask them to have the head up and irrigate more. So at least 3,000 smears is necessary to irrigate all the pelvis. And so if you have any cancer cell split, maybe you can flush it out. So we have data about the implantation is relative to the tumor volume. If a tumor volume less than 10,000 smears, then maybe they will not. But you more than 100,000 the concentrations, then they will have a high probability to have an implant. So the tumor volume also is very important factor. And if necessary, early adjuvant therapy, it will make the patient free away from the recurrence.
Another question is, what do you use to irrigate, saline or water?
We just use the normal saline. Yes.
Okay. I think we should thank Professor Lee for an excellent lecture on this difficult topic, actually. And now maybe we can welcome Dr. Chang to introduce our next speaker.
Thank you.
Yes, it's my honor. And we will move to the next topic. And Professor Xi Kun Lee. Professor Xi is a School of the Public Health, Chongqing Medical University Deputy Director, State Key Laboratory of the Ultrasound in Medicine and Engineering. And also, Professor Xi have a lot of the research and over 30 SCI paper in the past 3 years, and including 3 papers with impact over 45. It's amazing. And also published in the journal, including the Nature Medicine and the JCO. Also, the Professor Singh is also vice chairman of the Elden Oncology Committee, Chinese Anti-Cancer Association. He is also the vice chairman, Clinical Epidemiology Community, the Chongqing Medical Association. He is also co-chair of the China chapter of the International Society for Quality of Life Research. I'm sure the Professor Xi will give one wonderful topic. Professor Xi,
Thank
please.
you. Thank you. Thank you, Dr. Chi, for your nice introduction. And also thanks for Dr. Li. Long time no see. Hope to see you soon in Chongqing. And
Yes,
also
that's
thank Dr. Silva. And very, very great to get this opportunity to share our work in Chongqing and all over.
Professor Xi, I lost you. I cannot hear you. Professor Xi, are you here?
Yeah, I think we lost her.
Yeah, it is. They lost. Professor Xi, are you there?
Yes, I'm here. Maybe I'm calling Dr. Si.
Okay, please. Thank you.
Yeah, wait a minute.
In this moment, I introduced the Haifu situation in Taiwan. Actually, Haifu in Taiwan, it's just approved by the Taiwan FDA just for the myoma and the adenomyosis. But actually, in the world, the Haifu also to treat the enlarged lymph node or unclear abdominal mass. And I think for the cervical CA, maybe it's the other idea and the other action for the Haifu. And in Taiwan, the Haifu treatment for the patient, it will pay themselves, not include in the Taiwan National Insurance and National Medical Insurance. Okay, Professor C?
Oh, yes, Dr.
Yeah,
G.
you're
Sorry.
back again. Yeah.
Why? I got kicked out.
Okay, no problem.
Sorry.
Take your time. You have time.
Can you guys see my
Yes.
Your
PowerPoint?
PPT? Yeah,
Yes.
it is.
Okay. Yes. So as they give me the title and say to introduce some clinical research on how the Haifu treating HPV related diseases. But I think, as you know, you guys know my background as an epidemiologist and a biostatistician. I think perhaps I shifted my topic a little bit from the hospital to the community, because so in the next about 20 minutes, I'm going to give a very brief introduction of what we are doing in the community. Before, I'm sure all of those audience today, most of you guys come from a hospital, but right now I'm going to show you how those patients, before getting to your office, what they have experienced and what we can help them, supported by all the innovative technicals, including the laparoscopic and also the ultrasound, the focused ultrasound. So I'm going to get a very brief introduction of our projects supported by the Haifu, which is conducted, is undergoing in the community of a very small town in China. So as we know, WHO is developing a global strategy towards eliminating cervical cancer as a public health problem, which includes 2030 triple intervention coverage targets for scale-up of HPV vaccination to 90%, and twice lifetime cervical screening to 70%, and the treatment of pre-invasive lesions and invasive cancer to 90%. But if we achieve this goal, this 90, 70, and 90 target, what is going to be for all of our women, and can we reduce the mortality related to cervical cancer? In 2020, the WHO Cervical Cancer Elimination Modeling Consortium published their model, their estimation on whether these strategies can reduce the rates of cervical cancer mortality in low-income and lower middle-income countries. Their work is done in 3 core scenarios. There are 3 ones. First is girl only vaccinated at age years with catch-up for girls aged 10 to 14. This is a vaccination only project. And the other ones, besides the vaccination, they will have a once lifetime screening and cancer treatment. And then the third core scenarios was the girls only, besides the vaccination, there will be twice lifetime screening and the cancer treatment scale up, which is the WHO's 1970 and 19 that targets. So let's say what's gonna happen if we have that. In 2020, they estimate cervical cancer mortality rate across all those 78 low and middle income countries was estimated as 13.2 per 100,000 women. But by 2030, which is the time when the 1970-19 triple intervention target achieved, the first one, the S1 scenario, which is the vaccination only, would only have minimal impact on cervical cancer mortality with a 0.1% reduction. But if we look at if those girls got vaccination and also had at least one time screening, the mortality were reduced by 34%. And 40 years later, the S1, the vaccination only strategy will reduce over 60% mortality. But when we look at the WHO 1917-19 strategy, it will reduce over 90% of the mortality. And 100 years later from now, the vaccination only will show its significance. The mortality of cervical cancer will have nearly 90% reduction. And also, actually, the WHO, the 1917-19 in reduction deaths at age 30 to 69 years old would be 34% in 10 years, and also over 95% in 50 years, and nearly 100% reduction in 100 years. So what does this mean? Which means that screening and treatment still remain crucial for protecting women in 100 years. So I'm going to give a very brief introduce about the current screening and management and treatment of women with HPV infection. This is a report from Denmark based on its nationwide registered based data. So they look at the follow-up of the women with non-negative HPV screening test between March 2012 to 2016. For those who had positive or HPV test or inadequate HPV test, the adherence to recommendations during the first 3 follow-up visits is not that good. For most of our women at their reproductive age, they have over 61,000 of them. Only 43 of those who had a positive HPV test follow the recommendations during the first 3 follow-up visits. And when we look at those who are older, there's only 26 of them who are follow-up, who had the recommended follow-up. It's quite, remember this is in Denmark, in Europe. And then when we go to Argentina, they had a project for women aged 30, over 30 or older, and followed them for about 5 to 6 years, about 5 years. There are total nearly 50,000 patients. Okay, when we look at those over nearly 7,000 patients, 7,000 women had a positive HPV test. Only 26% completed the second test within the time frame. Look at this figure on the right of the PPT. The dark shaded bar is the time frame for recommended follow-up. You will see that actually very few of them, less than 30%, completed the recommended follow-up. As of March 2018, which should be 5 years later, the follow-up, the second retest of HPV just increased to 70%. Actually, there are many efforts to increase the recommended follow-up after a non-negative HPV test. The clinicians in Honduras conducted a cluster randomization study. And they said they found that among all HPV positive women, only less than 4% returned. And after the healthcare provider to recall and the proportion of those who returned to the follow-up increased to 71%. Just use a phone call and other reminders, contacts, like send a message or get into the in-person visit. So which means, yes, the retest or the recommended follow-up is quite low, but if the healthcare system can do something, a significant increase of those who got HPV test positive or go back to the clinic to have their retest or to have their follow-up for either treatment or retest. And in Denmark, they had a central, they had done a 1-to-1 cluster randomized controlled trial and to test the hypothesis that if we convene the cervical cytology result directly to the investigated women, whether this strategy will improve timely follow-up compared to the conveying the result via the usual way, which means the message is sent to their general practitioner first, and the practitioner will send this message to the women. They have this is a very large a cluster randomization controlled trial, and the result showed very good. The efficacy is very good. And by the third month after the positive result coming out, the intervention group had a 50% without timely follow-up rate compared to the 19.5% in the Euro group. And the difference is significant. So seems if we gave this patient, these women, some intensive contact or strategy, we can change something. We can change the current very low proportion and a very low rate of recommended follow-up. But what's in China? What happened in China? Actually, everybody knows that in China, we have 2 cancer screening programs supported by the government, which include breast cancer and cervical cancer. And by 2018, the cervical cancer screening rate already reached to 15 to averagely, it's 15 to 25%. But data for follow-up after a positive screening result is limited. I even cannot find any. So based on all those information we had back to 2021, we started a cohort study. We proposed a cohort to provide the adherence to recommended follow-up after the positive HPV test. The aim of this cohort study is first to describe the status of follow-up and to investigate what kind of factors to impact the decision-making for HPV infections, such as the follow-up and treatment, and also to identify potential factors which may influence the treatment decisions. Our ultimate goal is to provide the real-world evidence to support optimal decision-making in the management of HPV infection, and ultimately strive to achieve the goal of 90% of women with pre-cancer treated. This study was conducted in a very low income county. You will say from the map of China, this county is just set in the middle of our country. This picture shows this very beautiful place, but there are mountains all over the county. It's really hard to find a very flat place to get people together, to gather people. And this county is kind of back to 1990s. It had the second highest cervical cancer prevalence. And there were only in total 30,000 women aged 18 to 65 years in the whole county. Then we designed using a mixed method and a 5-year prospective longitudinal cohort study. For the cohort, women diagnosed as HPV infection during the nationwide screening program will be the participants, will be recruited. This shows the recruitment procedure, and those shows the follow-up procedure. The main outcomes of this study would be 3 outcomes. First, the compliance with guidelines. If you got a positive result, what should we do? And when the women coming back, what kind of treatment or management strategy will they choose? And also how the HPV infection status changed over the follow-up or over some treatment. So this table 1 showed the data collection schedule. It will be, we will have totally 8 visits. The first 3 visits will be complete during the first month of the screening. And after that, those women will be followed every 6 months. So to conduct this project, we used our own data management platform, which is a project-based data collection and storage platform. It accommodates the multi-projects and all projects protected by account and private account and password. The data access levels is controlled by researcher themselves, not by the engineer. And also we can define our own CRFs, and they have the ability to collect data longitudinally. And the clinician and the researcher can control data exports for analysis anytime if the PI wants the data. Then we have a WeChat mini program to connect the data electronically, which enable the high frequent patient data collection. For example, we can do the symptoms and the functioning data collection every day when patients are back to home. And this, based on this platform, the State Key Lab of Ultrasound in Medicine and Engineering is establishing the data network over the country. Right now, we already have 75 hospitals and over 30 million data on this board. And we use blockchain technology to provide a transparent, secure, and efficient way to manage data. Okay, this is the baseline investigation. We investigate all women in that county aged 18 to 65 years old, which right now it is a little bit over 21,000. We use questionnaires to get the information about their general health status, which also include their history of gynecologic conditions, include cervical diseases. You will see we use the PAD, here is a PAD, or paper-based questionnaires, and via face-to-face interview. Right now, in our cohort, we have total screening women up to just a little bit over 5,500. And currently the HPV infection rate is about 17%. It's quite a lot higher than that in the Eastern China. But I would say it may be because of the age groups, because in that county, all the young people the young ladies already got out of that countryside. They went to the big cities, and we cannot find that much young ladies in our screening program. And the follow-up is not that good. The 6 months follow-up is about 50%, and 1 year down to 20%. To the non-adherence reason, there are several ones. Lack of money, the transportation is difficult because all of those villages are spread in the mountains, and also they have to do child care or any other housewife's job. Also, they are hesitant on the effectiveness of treatments. For example, when the women with HPV positive test came back 6 months later, they found that their HPV is still there. So they feel kind of disappointed. So they won't come back next time. And also we found that for the girls under 14 in elementary school and middle school, the HPV vaccination rate is quite low, especially for those in elementary school. We interview the girls themselves and also their parents, and also the school teachers and the government officers, identify several barriers for vaccination. First of all of those, even the teachers, their parents thought those girls are too young to be vaccinated. Using this data, using the baseline data, we have conducted 2 cross-sectional studies. First is the HPV infection in older women. The purpose is to explore the epidemiology and factors influence the HPV infections. We use the cross-sectional design and the data extracted from baseline investigation of these cohorts. So those are the inclusion and exclusion criteria. We have published this paper, these results just 1 month before. And we included 2008 patients from 40 to 65, and 21% had a positive HPV test. And the prevalence of HPV infections increased by age group. You will say, please say the left one. The green line shows the high risk HPV infection. You will see that it increased by the age. And also the genotype of HPV in age groups are quite interesting. For those 40 to 59 years old, the top 3 was 52, 53, and 16. But for those older ones, the first one, the top 1 is 58, and then 52, 53, 16 is not there. And also, we identified that factors related to HPV infections, age at first marriage, younger than 18, and also if they have 2 or more number of pregnancy, and also the education level. They're all risk factors related to HPV infection, which suggests us some health education program should be focused on this group of women. And also we look at how those women, how the knowledge and the practices regarding HPV and cervical cancer screening. We also use those patients. And we have measured their HPV-related knowledge by 7 questions. And also we measure their attitude for willingness to receive the HPV vaccine. And also we define a regular screening as they have at least 1 screening for cervical cancer in the past 3 years. The preliminary result showed that for those who had, very few had a regular screening for those women. Over 80% would only have 1 time. And their knowledge of HPV is significantly lower than those who have regular screening. And also for the reasons for irregular screening, mostly is, I don't know. I should check regularly. And I don't know what can this screening benefit me. And I don't have any symptom, I'm good. I don't have to. No time, traffic inconvenience, and the fear of the procedure, all kinds of things. And also we found we had an attitude toward the HPV vaccine, which is surprising us. Actually, although there is a significant difference, everybody thought if I had a daughter, I would give them, let her receive the HPV vaccination. It's quite, yeah, it's a little bit surprising. Okay, those are our preliminary results. For future plans, we will have a very intensive follow-up cohort to enhance the follow-up, to recall those women back regularly and back as recommended. And we set up a small cohort in a village about 60 kilometers to the downtown. And we are introducing the new treatment technology, the Haifu, the focused ultrasound, in the HPV-related cervical lesions. This will be done. This is undergoing in our cohort. So in all, what I'm thinking, what I have done, we have done here, is that to show that the necessity to have a more specific and more professional management plan or strategies to those women who are got a positive result of their screening test, but after that, nobody care them, I would say. Even the doctors, the clinicians called them and say, oh, okay, you got a positive result and you should come back. And then nothing happened. There's no strategies, no plans, no healthcare insurance to take care of this. So I hope if anyone in the audience tonight can join us, we will have a big program in China, and we want to establish the mode to manage those women before they get into the doctor's clinic to treat their already invasive cancers. Okay, that's all. Thank you for your consideration.
Yeah, wonderful, wonderful presentation, and give us a lot of variable data and compare. Is there any question here? I think the time is limited, so I need to move to the other topic. Thank you again, Professor C.
Okay, thank you.
Thank you.
Our next speaker is Dr. Wang Zi, who will be speaking on focused ultrasound treatment for cervical intraepithelial neoplasia, CIN. Dr. Wang Zi is the Deputy Director of Clinical Training Center at Chongqing Haifu Hospital, Assistant Director of the State Key Laboratory of Ultrasound in Medicine and Engineering, Head of the Medical Research Department of the National Engineering Research Center of Ultrasound Medicine. She's a member of the Focused Ultrasound Therapy branch of the Chongqing Medical Association, standing committee member of the Cervical Cancer Comprehensive Prevention and Control Committee of the Chengdu Maternal and Child Health Association. I think all of us will be very interested to know this new method of treating cervical intraepithelial neoplasia. Dr. Wang Zi, please.
Okay, thank you, Dr. Silva. Thank you for your introduction. And okay. So it's my honor to share with you the focused ultrasound treatment for cervical intraepithelial neoplasia. And I will give my presentation from these two aspects. The first is the characteristics of focused ultrasound treatment. And the second is the clinical applications of focused ultrasound in cervical disease. So, not like the tumor system, focused ultrasound for cervical disease has the following characteristics. It adopts ultra-short focusing transducer with a treatment depth of about 3 to 6 millimeters, and the focal region is very small, with a long axis of about 3 to 4 millimeters. And when treating, the therapeutic ultrasound-specific coolant are used. And there's no smoke during the treatment, no ionizing radiation, and no respiratory effects on the operator. Since the normal tissue structure and the functions are not affected after treatment, it can be treated again if the disease recurs. As we know, focused ultrasound has good penetrability and energy deposition, which can directly deposit the energy into the deep tissue lesion through the epidermis or epithelial lesion. Due to the different sensitivity of different tissues and cells to ultrasound, under the appropriate dose, the diseased cells, tissues, and pathogens will be destroyed first, and normal tissues will relatively unaffected. So therefore, focused ultrasound therapy can treat the disease while maintaining the normal structures and functions of the tissue to the maximum extent. This is what we call the selective destruction of ultrasound here. And after ultrasound treatment, microcirculation and peripheral nerve functions can be improved, and the vaginal microecology and the immune environment can also be improved, promoting further removal of pathogens. That's why high-focus ultrasound treatment is effective and the recurrence rate is low. So the damage degree of ultrasound treatment is closely related to time and output power. These images show the ultrasound damage of beef liver in vitro. In fixed point scanning, the longer the scanning time, the greater the damage. But we can say that the depth of these injuries does not increase with time. So in the treatment, we don't have to worry about too much damage to the deep tissue. It is safe and controllable. And in clinical application, we often use the linear scanning, which can make the energy evenly distributed in the treatment area. According to different disease and the different treatment purpose, operators choose different treatment parameters and sonication methods. At present, the focused ultrasound treatment equipment used in clinical practice is independently developed and produced by China and is used for gynecological outpatient operating room. The scope of application includes chronic cervicitis, cervical human papillomavirus infection, and squamous intraepithelial neoplasia, vival white lesions and vival intraepithelial squamous lesions, and condyloma accumulatum. The device consists of a main engine and 2 treatment guns, one for the cervix and one for the vulva. Now, we'll focus on the clinical application of focused ultrasound in cervical disease. As people's awareness of cervical cancer prevention gradually increases, the clinical application of focused ultrasound in cervical HPV infection and the CIN is also increasing. There have been over 100 relevant papers to date, and more than 8,000 patients were involved since 2007. These are some data from the literatures. We can say that focused ultrasound can be used to treat not only low-grade squamous intraepithelial lesions, but also high-grade lesions. The negative conversion rate of HPV are from 70 to 94%, and the effect rate for low cell are about more than 90%. Now, let me give you a brief introduction to the treatment process. Cervical treatment is usually performed in 3 to 7 days after menstruation has cleared. The treated area is 2 millimeters beyond the lesion area. Circular scanning or linear scanning can be used both okay. The sonication speed is recommended to be 5 to 10 millimeters per second, and the speed is adjusted according to the response of the cervical tissues and the pain perception of the patient. The slower the scanning speed, the faster the energy deposition, and vice versa. There's no need to use anesthesia for cervical treatment. Patients may experience mild distension pain, which most patients can tolerate. Of course, the appropriate anesthesia method can also be adopted according to the hospital condition and the needs of the patient. So, the ultrasound dose is administered according to the response of the cervical tissue. When these changes occur in the cervix, the dose is sufficient to stop treatment. First, the volume of the cervix is reduced. The squamous columnar junction becomes wrinkled and not smooth, and the boundary becomes clearer. With the external OS of the cervix at the center, the cervix sinks inward. The external OS becomes slightly larger, and the hyperplastic tissue becomes flat. And we can see white patches or intermittent white and red tissue appear in the treated area. The tissue is slightly dry and the texture turns a little hard. This video shows the process of treatment. The transducer puts the ultrasound energy directly into the cervix by contacting the tissue. Apply a small amount of therapeutic coolant to the cervix. The operator just adjusts the treatment technique and intensity according to the different reactions of the tissue, so as to achieve personalized dose delivery. The cervical treatment time is very short, and the sonication time is usually within 3 to 5 millimeters. The whole procedure for one patient is a little over 10 minutes. During this period, we consider had no smoke and no ionizing regulation. So immediately after the treatment, the cervical tissue indicated congestion, tissue shrank, and a slight inward depression in the center, centered on the external OS of cervix. The management after treatment is similar to other physical therapy methods. Anti-inflammatory and hemostatic drugs can be applied locally immediately after the treatment. Keep the perineum clear and refrain from sexual intercourse and vaginal irrigation for 2 months after treatment. Generally, systemic antibiotics are not required. So during post-operative recovery period, it's normal to have vaginal discharge and a small amount of bleeding for some patients. No special treatment required. Just avoid the strenuous exercise and heavy physical labor. If the ultrasound dose is too large, resulting a large amount of bleeding, hemostatic drugs or pressure hemostasis can be used. The incidence of complications requiring clinical interventions is less than 1%, and patients' symptoms and cervical hearing were followed up 1 to 3 months after the treatment. So because virus clearance usually takes some time, so HPV and cytology tests are usually performed 6 months after the treatment. There are correloscopic images of high-risk HPV infection patients with low cell in our hospital. Before treatment, immediately after treatment, which we have talked about before, and this is 3 months after the treatment. We can see the cervix was covered by squamous epithelium and appeared normal. There were no adverse reactions such as cervical tube adhesion and scar contracture. The patient's HPV had turned negative at 3 months after the treatment. Although there have been a few reports of HPV turning negative in some patients at 3 months, but we still recommend evaluating the efficacy at 6 months. These are correloscopic images of CN2 patients before and after treatment in a literature published by the affiliated hospital of North Sichuan Medical College. The patient is a 28-year-old woman, HPV 58 positive. The cervix was covered by squamous epithelium 6 months after treatment. Cervical tissue biopsy showed normal squamous epithelial cells and negative for HPV DNA test. This is a case report published by the second affiliated hospital of Chongqing Medical University. A young patient had high-grade cervical lesions, and the HPV turned negative 3 months after treatment, and the lesion disappeared. This patient was pregnant 8 months after treatment and delivered twins at term. There was no recurrence of CIN at 18 months follow-up after treatment. The treatment of CIN with focused ultrasound is safe and effective and provide a new choice for clinicians. Selecting the right patient is a key factor in the success of treatment. There are currently no clinical guidelines for the treatment of CIN with focused ultrasound. So we mainly refer to the criteria of ablative treatment when selecting patients. That is, after adequate colposcopy and the lesions were completely visible and there were no high cell in the cervical canal. Invasive carcinoma and granular epithelial lesions were excluded, and all patients should be given full informed consent and have good compliance. Due to the good protective effect of ultrasound treatment on cervical tissue and no adverse effect on fertility, it is mostly used in clinical treatment for young patients with fertility requirements. However, the therapeutic principle and operating process of focused ultrasound is not the same as that of other ablative treatments. It is worth thinking about whether the inclusion and exclusion criteria for ablative therapy are fully applicable to high focused ultrasound therapy. It is still necessary for more clinicians to invest in the study of focused ultrasound so as to develop specific clinical standards to treat cervical intraepithelial neoplasia. And there are some basic research on focused ultrasound. A study of the effects of low-intensity ultrasound irradiation on cervical cancer cells and the related mechanism of cell death show that the apoptosis rate at 6 hours, 12 hours, and 24 hours after ultrasound treatment was significantly increased compared with untreated cells. And cervical cancer cells were more sensitive to ultrasound irradiation and more susceptible to kill than normal cells. It shows that the selective effect of ultrasound on tissue cells, which we have mentioned before. Another study showed in 154 patients with CIN, the ERAP1 expression was increased in cervical tissue after ultrasound treatment. IgA and IL-10 in vaginal lavage fluid were significantly decreased. It suggests that ultrasound can not only directly treat lesions, but also improve the local immune environment of the cervix. And this study was to investigate the clinical efficacy and the possible mechanism of ultrasound treatment for CIN1. It was found that the expression of P16 and Ki67 was down-regulated, and the expression of FAS was increased 3 months after treatment, indicating that the focused ultrasound can regulate cell proliferation and promoting cell apoptosis. Most patients with cervical disease have vaginal flora disorders. The study, which includes 37 patients with low cell, showed that the vaginal microbial diversity was decreased after ultrasound treatment, thereby promoting the restoration of vaginal flora. So in all, focused ultrasound therapy has significant efficacy, safety, no ionizing radiation, smoke pollution, and does not affect fertility and is worth of clinical promotion. At present, there are no clinical guidelines for the treatment of CIN with focused ultrasound, and the treatment still depends on personal experience and the technical level of the operators. We have seen the value of focused ultrasound in preventing cervical cancer, but the high quality and the multi-center clinical trials are the direction of future research. So that's what I want to share with you today. Thank you.
Thank you very much for a wonderful lecture. This is the first time I'm listening to focused ultrasound used for cervical cancer, for CIN, although I've seen this machine in Chongqing, but never got around to learn to use it. I see whether there are any questions. There are no questions in the question box. Perhaps I can ask you, it's very interesting that you say that it only involves about 3 to 5 millimeter depth of the cervical area. If you burn at the same area that you have burnt, will it go any deeper, or it will just stay at the 3 to 5 millimeter depth? I don't know.
The focal region is about 3 to 4 millimeters, but the treatment area can deep in almost 6 to 7 millimeters. And for this machine, but if you want to treat some deeper tissue or other, we can choose another transducer maybe.
Okay. In your study, just by killing this 3 to 4 millimeter of the cervical lesions, you can eradicate CIN, say 1 and 2, and also HPV. That's what you're saying?
The deepest side is 3 to 5, but you can destroy the whole layer of this epithelial layer.
Okay.
So,
I understand. I don't see any other questions. How popular is this machine in China? Is it approved for usage for CIN in the whole of China? I don't think it's available outside China.
In China, we almost have more than 1,000 hospitals to use this machine for cervicitis, almost cervicitis. And for HPV infection and CIN, maybe less hospital. More than 100 hospitals use this machine to treat CIN. And that's what we do in China.
Besides Chongqing Haifu company, are there any other companies making this kind of machines for cervical lesion?
Maybe only 1 or 2 more company, but almost 99% of the machines produced by Haifu, Chongqing Haifu. Just some seldom for other company.
Is it available in Taiwan?
I'm not sure.
Not yet. In Taiwan,
not yet.
Not yet. But I'm very interested in this machine. But first, it must need approved by the Taiwan FDA.
There's a question here. How long was your follow-up of patients treated with this method? Do you have a long-term follow-up of patients who have been treated with ultrasound, this ultrasound technology for CIN?
So now the data are not so how to say, not so enough. So maybe the longest follow-up time maybe 1 or 2 years.
Okay. I don't know. This question says, any decrease in incidence in CIN or cancer in cities that use this technology? But I think it's being used only for a few years, so it's very difficult to answer this question, isn't it? To have an effect on the society. Yeah. I mean, my interest is that it looks like compared to say LEAP, which is probably a standard treatment, that means we excise the cervix. This is a very non-invasive kind of treatment that storing the cervix, and especially when we are worried about women going into when they get pregnant,
Yes.
preterm labor and miscarriages and cervical incompetence. So that probably is where ultrasound energy will be most useful, I think.
Yeah, that's right.
Okay, and I think you also mentioned that it is currently not recommended for high grade SIL, only say low grade. Am I right? But you have already shown one data that say that it actually works very well with high grade CIN.
You mean high cell weight?
High cell, yeah.
Yes. Some doctors have found that the good effective of high cell, but we have not enough patients, enough data. Yeah, maybe we need more multi-center research.
Okay. Okay, I think our time is probably up. I think we can I invite Dr. Chi to say a few words before we end this webinar. Okay, Dr. Silva, there are 3 questions in the chat box. Let me see. There's some more questions here. Sorry, there's another question. Are there any comparative study with other modalities? Yeah, it's a good question. And this probably you don't have any comparative studies for comparing focus ultrasound with cryosurgery or LEAP or cone biopsy. Do you have any comparative studies yet?
Yes, we already have some, but I haven't show you on this PPT. Maybe next time we will show you some other trials. Yes, we already have some to compare with the other methods.
Okay, there's one other question. Is there any patient who develops cervical stenosis after this treatment? That means the cervical os become tight.
Sorry?
The question is cervical stenosis. That means when you do this Haifu, the hole becomes very small. It becomes very small. Do you have this kind of problems?
After treatment, is there any patient have the stenosis of cervix? 子宫颈治疗后有没有狭窄过？
No. We haven't found any patient to get the attention with the cervix tunnel.
Okay, I think I've covered most of the questions here. I think we probably can. Anything else? Any other questions? I think no more questions.